My name is Robert Weinmann. I'm a physician in San Jose. I helped bring the doctors into the union movement in 1997, but we have been an independent union before that since 1972. The doctors formed an independent labor union founded by Sanford Marcus in 1972 called the Union of American Physicians and Dentists. In 1997, after I was president for a few years, I brought them into the AFL-CIO, and we are now Local 206 of the American Federation of State, County, and Municipal Employees. I'm no longer an officer in the UAPD and do not speak for them at this time, but I'm still a member. From the beginning of my career, I would see injured workers from time to time. It's become increasingly difficult to get treatment for injured workers. It's become easier and easier for insurance companies to arbitrarily and incorrectly reject treatment for injured workers. There has been more and more governmental support of outside contractors and the like to aid and abet in rejecting care for injured workers. All of this is under the guise of expediency and improvement with reference to regulatory control. By the time the injured worker hears about it, it's too late for him to do anything about it. So that, for example, just today, a patient that I had referred for neurosurgical assessment at Stanford was turned down. The reason he was turned down was because he was told they don't accept workers' comp anymore. Now, I know better. I know they do some workers' comp. It's not like they across the board reject everybody. But this is the second neurosurgical patient that I've had turned down because he's on workers' comp. They were not given appointments. Now they will go someplace else. But the point is, the climate has changed so much that places that don't have to do workers' comp don't. Governor Schwarzenegger wasn't really a governor. He was an actor playing governor, and he did pretty well in press conferences. As a matter of fact, he was the only governor that I turned down a face-to-face meeting with as a photo op. I got one of the invitations from the governor to appear with him in a photo op for $5,000. I sent him back saying if he'll come meet with me in Oakland, we'll only charge him $2,000.
And what did SB 899 do?
Basically, it took workers' comp out of the hands of the Workers' Compensation Appeals Board. It meant that decisions are made more and more by insurance companies, per se. The purpose of an insurance company is to make money for its stockholders, for its owners, to enhance corporate compensation. Those are legitimate business interests, and they come before treatment of injured workers. We were against it.
And what did you argue?
We argued that it was going to reduce care for injured workers. But you understand, you didn't have a lot of chance to argue on that bill. It was passed like with an hour's notice. Shows that the legislature, when it wants to do something behind the scenes, can do it. There was not much debate on SB 899. It was not exactly held up to the public for public comment and scrutiny. In fact, it was rushed through proverbially in the dark of night in the middle of the day.
And what did it change as far as the law?
It basically disenfranchised the injured workers, but I don't really want to talk about 899 that much because it's old, it's gone.
Okay.
We could have lived with 899 by itself because much of it was so flawed that bit by bit it was being overturned. 863 is the bill now that has put the nail in the coffin.
In regard to 899, the California AFL-CIO was silent on it.
Yes.
It was neutral on it. Why was that?
Probably because they were in league with the business interests. A lot of times big labor is in league with business interests. After all, everything in America is business. My own union has a pension fund. My own union is interested in the stock market. I am interested in the stock market. Almost every American is interested in this country doing well. Now, in some ways, that sometimes means cooperating with business interests. And sometimes you have to ask yourself, which interest do I connect with more? I remember one time when I was talking to Governor Brown about this in the days when I could talk to Governor Brown. He pointed out that there was a Medicaid bill that was before him. And he understood the merits of the bill. And he understood that if he signed it, he wouldn't hear a single bit of applause from Medicaid patients who now got covered. But he knew that he would get an avalanche of criticism from the people who didn't want to pay into the system. They don't get it. For example, there's a book of rules and regulations. It's not a medical book. You don't use it in medical school. You don't use it in residency or internship training. Nurses don't use it. Nobody uses it, except people who do injured workers. And it's an attempt by one of the professional groups, the American ACOEM, second edition, and MTUS, Medical Treatment Utilization Schedule. It is an attempt to give people guidelines about when you qualify for surgery and when you don't, and so forth and so on. Now, the first edition of the ACOM guidelines had about the first edition of the American Medical Association's guidelines had approximately 81 typographical errors in it. They were all significant because each one of them had to do with a number that affected the injured workers. Sometime after it was issued, they issued a correction of the 81 by sending out a glossary. Most people still don't know what those mistakes are. Now that is of interest because sometimes when a patient gets rejected, you will get a little sheaf of paper and they'll say, these are the reasons why your treatment was rejected. And you will notice when you look at that it includes the entire section about that anatomical body part, only a little bit of which might actually be relevant to your patient. But you can tell when you get it that the person who sent it out didn't know what part to choose. So he sent out the whole thing.
So are you saying non-medical people
Yes.
are making decisions on medical treatment?
Yes, and here's a hint for your injured doctors. When you get one of those lengthy denials, you do what I do sometimes. I just recopy it and send it back and say it's my reason for doing it. So they send me 5 pages saying why I can't. I send them the same 5 pages back saying why I can. Well, 863 initially was supposed to get an increase in permanent disability, which had been harmed by previous legislation. And the idea of permanent disability was to make sure that people who were permanently injured had some coverage in the future. And SB 863 was going to get a significant increase in permanent disability. I did not object to that. The unions did not object to that. In fact, the unions kind of liked it. That was a good thing for California Federation to push. That was a good thing for the injured workers. But the insurance companies in itself didn't like it because, of course, for them, it was a bad thing. Okay. Well, it was not in the political cards just to object across the board to this bill. Because by this time, 899 had made such a shambles of workers' comp that it was clear that some changes were needed. So labor backs up permanent disability, but the insurance companies say, well, we need some adjustments if we're going to go along with this. Now you step outside of workers' comp and you find out that at the same time the governor was pushing a bill for taxes. That was Prop 30. And you find out that the insurance companies were saying such things as, well, if you give us a little something on this bill, we won't be opposed so much on that bill. And now you get political trading, which is part of the political process. And even though I don't think that's a very good way of doing government, I don't particularly object to it, because when you have thousands of bills, well, they can't all pass, okay? So deals are made. Now, one of the deals that was made in the permanent disability section of age 63 was to cut out psychiatric, to cut out consequences of pain that cannot be successfully treated because the surgery or whatever it is that needed either can't be done or isn't going to do enough. And this affects largely construction workers, people who do heavy work. And labor said, okay, we'll take those things out. We won't go for that. And so all of a sudden the permanent disability that they were fighting for was reduced by approximately 50 million or so. Okay? In return for that, the injured workers got treatment. So, for example, the bill says, while we are denying this for permanent disability purposes, we are not denying it for treatment. Therefore, the Labor Federation was able to say, we're not denying treatment. We're just making an adjustment. They didn't talk about it too much, because they didn't want to tell injured workers that so many things were being denied: pain, spinal surgery, and so forth.
How is spinal surgery being denied?
Spinal surgery is denied a lot when you ask for a surgical consultation. All expensive procedures really get reviewed. Now, let's say I want somebody to have spinal surgery, and this is my record on them, and I hand it over. It turns out that Maximus sometimes doesn't get this record.
And who is Maximus?
Maximus is an outside contractor that makes medical decisions when they have initially been reviewed and denied by utilization review. This is really the heart of the matter that I'm involved in. For example, but let me finish just a little analogy. I may hand over this as medical records and say, here's why he needs the surgery. But if somebody does this, a little sleight of hand, and gives Maximus only this, or maybe only that, pretty soon Maximus's doctor can't make a decision based on the records. So he says no. Or,
and who are the Maximus doctors?
well, they're sort of anonymous people whose identities are protected. And
was that the change in the law?
That was one of the changes in the law.
Why have anonymous doctors?
The theory would be so they can't be lobbied. Okay? The theory would be so that they make the decisions based only on medical stuff and not based on knowing somebody. Okay? But as it turns out, the insurance companies can call lists of doctors. And before they appoint somebody as a utilization review doctor or to the independent medical review panel, we can know pretty much if he's an applicant-oriented doctor or a defense-oriented doctor. Now, neither category is particularly bad or particularly good. One can say, well, the applicant-oriented guys might operate too much. One can say the defense-oriented guys might operate too little. But in the spectrum of peer review, we're supposed to be able to tell the difference, and pretty soon we get people making proper decisions. It's not hard to do, actually. There's a handful of times when you can't decide whether to do an operation now or tomorrow or never. That happens, okay? But most of the time we can arrive at a reasonable decision. But what we can do all of the time is make sure that our doctor leans one way or the other before we hire him. You can't really appeal very much except by spending a lot of money and time. There's a provision in the law that requires the doctor who wants to appeal the decision to pay $335.
So they want the doctor to pay.
Well, that's a bill review. That's a bill review. And it really works out very well, because let's say you have a $50 billing dispute. Okay? Are you going to file $335 in order to get a $50 billing? No, you're not. Okay? Or let's say you have a denial of care before the bill review is even at stake. How much money do you want to spend fighting with a bureaucracy? Okay? How much time from your office do you want your staff to spend fighting with the bureaucracy, saying no, you can't do something? So many doctors don't fight with these things.
And have doctors left the practice of taking care of injured workers?
Oh yeah, but in droves. But that's good for the insurance companies because now they don't have to pay for the care because they can't get it. And now it's the doctor's fault, right?
And also this issue of opiates, increasing use of opiates and doctors being blamed for that. Why don't you talk about the growth of the use of opiates in California? There was a study, Rand Department study, that said that there's increasing use of opiates and addiction of California injured workers.
What happens is this. Somebody gets an injury or somebody gets a complaint, say from a head injury, that the headaches won't go away. A common way to treat pain early on in the acute stage is with Vicodin or Norco or some opioid. And the idea is that these medications work very well on the short term. Over the long term, they have other problems. Not just addiction. They even can contribute in the long term to continuing pain. But let's say a patient, by way of example, has injured his shoulder. And you are trying to get him back in shape. You're trying to avoid surgery, but maybe you have to do surgery. But in any case, you have to treat him for pain either way. Let's say that he has his surgery, and now the doctor thinks he needs about 30 treatments of physical therapy. But he doesn't know. Maybe it'll be 40. Okay? It turns out that there is no study anywhere in the world that shows how many treatments somebody should have for physical therapy. We only know from Army and medical and military experience and long-term practice that some people need longer than others. But we do have a rule that says you're only entitled to 24 physical therapy treatments. Now, this is in a context where you're supposed to have evidence-based medicine. There is no evidence showing that 24 is a proper number. None whatsoever. It's arbitrary and capricious. It can sometimes be overturned, but how many doctors really think that they want to fight that sort of thing? Most doctors aren't into that. They know how to take care of patients, but not how to fight bureaucracies. And many of them don't want to fight bureaucracies because, especially if they work on a salaried basis, especially if they work for somebody, that's not what they're paid for. They're paid to see a certain number of patients every day, not to fight with bureaucracies, and half of those patients don't get seen.
So are you saying that basically doctors who treat injured workers are not really able to give care because of a bureaucracy and obstacle courses that doctors have to go through in order to get compensated?
Well, let me point this out. Yes, that's what I'm saying. Point out that the example I used of the shoulder injury, somebody needs a physical therapy and it's denied. And he gets a sheaf of paper showing why it's denied. Now what does the doctor do? He may have tried to get physical therapy, he may have tried to get aquatherapy, he may have tried to get acupuncture, he may have tried to do a number of things, but it's all turned down. The only thing that's left is pain medications. So he prescribes them. The patient is grateful because that's better than nothing. And now we have a patient on long-term opioid medication, and the doctor gets the blame for it. If worse comes to worse, they can explain to the medical board why they helped to addict the patient. But in any case, they get blamed by the insurers for prolonging care, over-prescribing.
But it's good for the drug companies, isn't it?
Well, yes, and sometimes selling the medications is good for the drug companies. But you know what? They make enough different medications so they don't have to sell only just opioids. They can sell other medications. The drug companies have a stake in this.
So there seems to be a growing problem with depression, psychological injuries from bullying in the workplace and other kinds of psychological industries. And when you get injured, a physical injury, then you have psychological problems because you get depressed and you have depression. Are you saying now that for injured workers in California, who's going to take care of them, these other problems that they have as a result of physical injuries?
It's a problem. Getting things done in workers' comp is a problem. You have to enjoy the administrative fight. I kind of like that sort of thing, so it's okay. I'll do it to a certain extent. But I limit myself too. I mean, I can't spend my entire day doing this.
And most doctors don't.
No. For example, the patient today who called up, Stanford refused his neurosurgery. Well, he can go someplace else. He can. Someplace else will accept him. I have no idea about it. I like to refer to the people that I know can do the job. But the fact is, most of the people can do the job, even when I don't know who they are. I don't know what kind of pressures they are under some places. And I don't know about the ancillary care. But I do know that I wanted this patient to go to Stanford for neurosurgery because the doctor there had done a good job on some previous patients of mine. And the last 2 referrals that I've made him were both turned down because the patient was on workers' comp. So I'm not saying he wouldn't do the surgery. I'm saying he couldn't even schedule an appointment. And I don't blame the doctor. I believe that that was an administrative decision based on unwillingness to work with workers' comp because it's useless, it's uncooperative, and it's all contracted out to a company by the name of Maximus, which got paid $40 million.
And at this hearing, the Division of Workers' Compensation, they said that the system was working good. There was a study apparently put out by Maximus saying that there were good results. And the doctor, medical director of the Division of Workers' Compensation, said that, in fact, the doctors should be advocates for their patients. What do you? And you saw the interview. What do you think about that?
Well, the doctors are advocates for their patients. That's why they get utilization review denials. The doctors have sent out requests for treatment. They get turned down. The doctors have advocated for their treatment. As for the Maximus saying that there have been good results, well, how about this? Of course there have been some good results. Anybody can say that. The worst physician in the world has had some good results, and the best physician in the world has had some catastrophes. Maximus is approximately 80% behind on covering its own claims. Okay? There are.
How do you know that?
Daisy Bell has done the research on it, and giving Maximus the result, the benefit of the doubt, and using their own figures, we can see how far behind they are in responses.
And what does that mean to an injured worker?
Well, basically it means that, first of all, when the injured worker is denied treatment, he doesn't get it. When the doctor is denied payment, then he doesn't do the next case. So the worker falls off the ladder both ways.
And what happens to these injured workers? Do you have experience with them?
Some of them end up on Social Security when they could be back to work.
And the other issue is if you're not taken care of promptly, your injury deteriorates, gets worse, and then you end up permanently disabled. Do you see cases of that?
Yes, we see that. But we also, that's a slippery slope, because there are sometimes when not doing something properly is a good thing, like rest. People with carpal tunnel syndrome, for example, will improve if they don't do anything. But of course, if they don't do anything, they're not working either. Okay? So there are times when you don't operate properly, but you do something. And very frequently, utilization reviews stands in the way. I see a patient and I recommend treatment. As a consultant, I recommend treatment. It goes to utilization review. Utilization review looks at it, and maybe that doctor isn't convinced. Now, I will not know what medical records he got to review it. Maybe he got the full file, maybe he didn't.
Who submits the full file to him?
The insurance company and the adjuster. Okay?
So you can't submit yourself, your file to them?
I submit my records to the adjuster or to the insurance company.
So in other words, the insurance company is the person or the group or the agent that actually submits these?
That's what I believe.
And what does that mean?
But it could be well, it means that
agent or the adjuster or the insurance company is in charge of submitting the records. What does that mean?
Well, it means that if somebody's getting crates full of records all the time and can't keep up, maybe the adjuster, the insurance company, makes sure he doesn't get crates full of records. I recently got one that a medical file that weighed 76 pounds. Yeah. Well, I did every damn page, but it took 2.5 days or something like that.
And you get compensated for that?
In this case, I did. I think.
But I mean, it sounds like, I mean, this is becoming a big obstacle course for more and more injured workers. The process of going through utilization review and the independent medical review. I mean, it's what's a better? I mean, 863 was supposed to rectify or solve the problems of 899. You're saying that the problems have gotten worse.
No, it made it worse because, first of all, 863 did not fulfill its mandate to increase permanent disability to the extent that it tried to at the beginning. In order to placate the insurance companies, certain things were given up. Pain is the one we like to talk about most. Psychiatric was another one that we like to give up. We talk about a lot, okay? Right? And then some things were put in place. The independent medical review is what follows utilization review. And this gets so complicated when you're talking to people who don't deal with it all the time. For example, I was saying that I will write a report and recommend something, it'll go to utilization review. Let's say utilization review rejects it. Within a specified amount of time, I have to object to that. Now, I have discovered many times that the utilization review doctor did not get the complete file. But I don't know that right away. And other times, the utilization review doctor will be in a different time zone, Florida, Texas, something like that.
So you have an outside doctor who's not certified in California?
That's correct. That's correct. And Texas thought that this was such a bad thing that Texas a few years ago passed a law saying if you do utilization review in our state, you have to have a medical license in our state so that you can be responsible to the Texas Medical Board. You don't have to live here, but you have to be responsible to the Texas Medical Board if you're going to do utilization review in this state. California does not have that. In fact, California fought it down, and Governor Schwarzenegger and Governor Brown fought it down. That's one place where the two Republicans agreed. Okay? Indicated it wasn't necessary. There were enough safeguards in place, and furthermore, the HMOs did it. And now it turns out also that HMOs are not allowed to do this either, but the penalties are so slack that nobody cares.
What are the penalties?
For the HMOs, I don't think there are any. Maybe you pay 25 cents per every 100 years for everything that you did wrong. That's something minimal, some slap on the wrist. But I don't want to get too far afield. The utilization review doctor may object to something. Now, the utilization review doctor in Florida may or may not be licensed in California, and he may even give me a call while I'm busy with another patient so I can't talk to him. Right? He will then write down that he tried to make the call, but the doctor at the other end didn't take the call. And then he sends in his report, okay, showing the treating doctor's failure to comply, failure to cooperate. Okay? Meanwhile, you may find out that the outside doctor isn't even close to your specialty. You may even find out, as is the case sometimes, that the outside doctor agrees with the treatment that you want to do, and if it were his patient, would do the same. But he is obliged to go by the ACOM guidelines or the MTUS guidelines, and it may be that the medical records you submitted did not fulfill all the criteria of administrative bureaucracy. So he's obliged to turn it down. But you don't know that exactly at the time it's turned down. You know that your patient didn't get treatment, even though you are in a medical provider network that have presumably already screened you. And that's another thing the doctors are worried about. They're worried if they get too many fights with the utilization review people, they will be kicked out of their MPNs, and they can be. And they don't have to do anything wrong. It can be a business decision. One of the really real problems in this is that the Division of Workers' Comp does not go after the insurance companies with the same vigor that it might go after the doctors. One of our complaints is actually just that. We have repeatedly pointed out that the Division of Workers' Comp often just slaps on the wrist the insurance companies. Here's something from Daisy Bill. Daisy Bill is a billing network that's created. It's a new business that's created out of this. So I'm in favor of this business because, and they say, we would like to point out the lack of effective penalties when insurers consistently and flagrantly fail to comply with DWC regulations. Many insurers and their agents demonstrate a clear pattern and practice of incorrect bill processing, but current penalties are inadequate to the task. Now, on the other side, your medical provider network, which is owned by an insurance company or employer or both, can get rid of the doctors it doesn't want. And they don't have to accuse them of doing anything wrong. Just drop them for business reasons. So many of the doctors are really afraid to take on these issues.
So you're saying that doctors that handle injured workers because of the system are afraid really of taking on a system because they'll lose their positions as doctors if they do.
In the medical, they don't lose their medical licenses, they lose their association with the medical provider network.
And
right?
what does that mean?
Well, they don't get those patients anymore.
And what does it mean to the income of doctors?
Well, it doesn't do them any good not to work. So, of course, they lose. But people aren't worried about that. We have a society that thinks that all doctors are rich and are rich enough. It's the REA mentality, the rich enough already mentality. Okay? And so we don't have people who are really too sympathetic that docs don't get paid.
But in the relationship to workers getting treatment that they need, is there an issue for the medical profession about doctors not being able to treat people because of these obstacle courses?
Yeah, there is, and many of the medical organizations try and take it on.
Which ones?
The Union of American Physicians and Dentists, for example, recently wrote a letter in support of Senate Bill 626 of Senator Bell, which was going to take that on. But
What did that bill do?
well, it didn't do anything because it was going to be supported by Senator Wessel in the Labor Committee hearing, but there were not enough votes for it. The bill was pulled last week, and it's dead now.
And what would the bill have done?
It would have taken care of some of the problems of 863. Some, but not all.
And who was opposed to the bill?
Insurance companies.
What about the labor movement?
Actually, the California Labor Federation was also opposed to the bill. The California Labor Federation has a peculiar role in this. They supported SB 863 from the beginning, and when they were going for a full measure of permanent disability, had a good argument. They gradually sold their own bill down the tubes when they accepted all kinds of restrictions on injured workers. One of the restrictions they accepted was the outsourcing to Maximus. Now get this, a labor union which fights outsourcing, as did my union last year successfully in a certain group, ordinarily does not support outsourcing. But the California Labor Federation stood by while independent medical review was outsourced to Maximus.
Why would they support outsourcing? I mean, there could be jobs in California. There's a state company that could do that. I mean, why outsource the system for reviewing the situation of injured workers?
In my opinion, because the governor and the insurance companies together wanted it. And this was an irresistible position for the business hierarchy in the California Labor Federation. They have not had an internal revolt from their own members. They appear to have made, within their own membership, a correct decision.
Well,
just a second. I want to make sure. Okay.
okay, now, when this 863 was proposed, what role did the injured workers and doctors have to clarify and discuss the effects of this bill?
Well, when they're at the hearings, such as there were, you could present testimony, but I have been in testimony maybe hundreds of times at the state and federal level, and basically, before you go into hearing, you know what the vote is going to be. You know, when there's only 1 or 2 vote difference, you can make a real difference at a hearing. But mostly, by the time we get to a hearing, we know what the lay of the land is, and what we're doing is to show our membership where we stand. Okay. On 863, the California Labor Federation really was aligned with Governor Brown and with the insurance companies. Rank and file labor unions that could have influenced CalFed pretty much stayed out of it. SB 863 was dead in the water on a Thursday night before the final vote. When Governor Brown saw the bill was in trouble and he wanted it to pass, he knocked on doors. He did what governors are supposed to do when they want something. Unlike Schwarzenegger, who made phone calls sometimes through his aides, Brown knocks on doors and does the real job. Well, that's a very hard thing to turn down. The governor wants something, and you represent people who won't appreciate what you've done for them if you object to the governor. So you go along with the governor, and that's what happened.
And were any injured workers organizations in favor of 863?
Well, California Labor Federation backed it up. You said in favor, right?
Yeah, I mean injured workers groups.
Oh, injured workers groups. Oh, heck no. But they weren't effective. The injured worker groups were against it, and they said why, but they weren't effective.
And did they relay that to the California AFL-CIO?
Yes.
What did they say?
We'll take you under consideration. Come back next year.
So they ignored these injured workers?
Oh, basically. They got polite hearings, and nobody turns down, nobody refuses to meet with them. But, for example, at the hearing last week, where Attorney Martinson asked a question about oversight, Chairwoman Overpeck replied that she would get back to him. Well, so Attorney Martinson wasn't ignored. His question on behalf of the injured workers wasn't ignored. But I don't think Overpeck has gotten back to him yet.
Now, the injured workers, because of these obstacle courses and the problems, I mean, you almost have to be a lawyer. I mean, or you have to learn about the whole system in order to get medical treatment if you're denied.
That's right.
You know, is that a healthy thing for society, that you have to be basically a trained person to understand the whole system before you can get care?
No, yesterday I was talking to an injured worker, and he was telling me his legal problems. I said, "You're talking to the wrong guy, I'm not a lawyer." I said, "Talk to your lawyer." He said he did. I said, "Oh yeah. What'd your lawyer tell you?" He said, "Well, when I got a panel QME, he helped me pick the doctor I should go to. But he hasn't taken my case." Another time I was talking to an adjuster who sent us a panel. My name was on it, and he had crossed it off. He made a mistake. He didn't mean to send me that. Somebody faxed me the wrong document. So the adjuster was trying to shift a worker to somebody else on the panel, and I saw who he was. He said, "Use this guy."
Is that legal?
I don't know if it's legal or not, but both sides do it. One side tries to get the most defense-orientated person. The other one tries to get the most applicant-oriented person. Both sides say they're just trying to get the doctor that they believe is the most accurate and would be fair and unbiased. They both say that.
Do you think the insurance company should be in charge of health care and the situation of injured workers?
Probably not.
Why not?
Well, it hasn't worked out too well. It doesn't work out very well for injured workers. You see, one of the reasons Maximus got this job is California Labor Federation argued at this hearing that the current way it was being done prior to SB 863 was that judges were making decisions. Workers' compensation appeals boards were making decisions about medical care, and that medical care should really be made by doctors. That sounded good. So that goes through, and Maximus, which hires doctors, gets the job. So why isn't it better? Well, it turns out that it isn't. It's worse. Because now the injured worker is totally reliant on an anonymous source that 80% of the time has rejected his claim, rejects injured workers' claims. Now consider this. If that's so, that means that 80% of the treating doctors make wrong decisions. And now if that's so, then we've got an improvement. Then how come the injured workers aren't getting treatment? In my opinion, that getting this out of the judicial system turns out to have been a mistake. We were better off with the lawyers than we are with Maximus.
And what about getting the lawyers and all these other people out of the treatment business of injured workers?
That would be better too. And so there have been a number of proposals that have been recommended. For example, single payer. You want decisions made completely by doctors. If you listen to the debates recently on Obamacare or the Affordable Care Act, you would have heard Obama asked at one point in the second debate, what about the Independent Payment Advisory Board? That's Section 10320 of Obamacare. And Section 10320 allows for the appointment of an independent panel to review what procedures should be covered. Everybody presumed that those would be doctors making those decisions. And when Obama was asked about it, who would make those decisions, his answer was, quote unquote, doctors, etc. That's it. That's what he said. Doctors, etc. Well, he was wrong. There is nothing in that legislation that requires doctors to make medical decisions on the Independent Payment Advisory Board. Previously, it was known as the Independent Medicare Advisory Board. And that's when Sarah Palin came charging out saying they were death panels. Well, Sarah doesn't do her homework so well sometimes. There were no death panels, but there was a commission that didn't have to be doctors that was going to decide about when medical care could be covered and when it couldn't. Now the IPAB, as it is now known under the Affordable Care Act, has not been appointed yet. But when it is appointed, each person will get a salary of $165,000. And none of them needs to be a doctor. Now my guess is they'll find somebody with a medical degree to be on the panel. And they'll have a doctor. They'll have a nurse. They'll have a something or other else. Okay? But if that's what you mean by getting the insurance companies out of the business, then we're no worse, better off than before. We still don't have decisions made by treating doctors. And here's how the IPAB will really work. It's not a bad concoction when you think of government expenses. Everybody knows that when the Affordable Care Act starts, if it ever gets started, that after a while, it'll be paying out a lot of money. Because all the sick people will have signed up. And it may pay out more money than it takes in. So what are they going to do? Well, they will look through the list of procedures that is being done, and somebody will have to decide, well, this doesn't qualify anymore. It'll be analogous to what happened in Oregon a few years ago, when they decided that certain procedures above a line qualified for immediate treatment and others did not. And one of the procedures that did not qualify was laminectomies for discs, herniated discs. And I was very interested in that because that's the kind of patient I'll often see. And it often is not an emergency, even when the disc is herniated, because there are some people who actually have herniated discs who don't know it. They're not all symptomatic. Okay? So, what do? You just draw a line right across there. And then some people with Medicare benefits, once single payer passes, under the current system, under the Affordable Care Act especially, will find their benefits have been excluded. It'll be like, say, telling an army, go out and win that war, but by the way, we're not building any more tanks. Tanks are too expensive. Here's your armored vehicles.
Well, in the United States, we pay more per person for health care than any other country in the world. Yet so many people have not been covered. And even under ACA, for example, they're telling nurses, we're going to take away your health care.
It is true that we have these increased expenses, but the idea that, and a lot of people like to say how other countries have it better. Well, only a couple of years ago in England, a sensational case occurred when a baby with a brainstem glioma, a brainstem tumor, could not get an operation because there was nobody to do it. Because it was an ineffective procedure most of the time, it was deemed cost ineffective. They stopped doing it. And when it was needed, nobody could do it. And so they saved the cost on that and on all the other operations that would have failed. This is an operation that fails most of the time. So what do? Do it never? Okay, you save a lot of costs that way and you have a better statistic at the end. Okay? How about deaths after infant mortality? Does everybody understand which countries don't count infant mortality until after the first 6 months have passed? Does anybody? Yeah. People do know about these things, but not in general. So in general, if we want to use statistics like that, we can. Why are the Canadians coming to our northern border hospitals for operations? Why don't they just stay in Canada and get them? And why, when those buses bring the patients down to the northern border of the United States with their Canadian patients for the American hospitals, why do they leave when the American patients are going to Canada to go to the pharmacies? If money is the important thing, then these programs are effective. And I'm not going to argue that it isn't. A lot of people want to live in this country. And they come from countries where they think the health care is better. Well, they don't worry about that. They come here because here's where the opportunity is.
Now, a lot of these injured workers, so the state of injured workers in California, you're saying, is declining.
Yes, in my opinion, the situation for injured workers in California is becoming increasingly desperate, and the reasons are wrongful denials by utilization review that are in turn supported by even more wrongful denials by the independent medical review process and by Maximus and its ilk in particular.
And what hope do you see of changing it? And what should people do in labor to change it?
Keep fighting. That's the way we do things in America. You just don't get tired of fighting. It's not the sort of thing doctors do. The same doctor, for example, who when the bombs are falling or there's combat in a war zone will be out there right in the middle of it, taking care of his injured worker as if there were no bombs, who will be ignoring the machine gun flak while he's trying to start an IV on some patient out in the battlefield. That doctor, he's the one who's afraid to talk to administration when he's back in civilian life. Or for that matter, even when he's in the Army and he has to fight administration about something like an extra package or something. That's right, doctors don't like confrontation. The challenge of a difficult patient, that's what a doctor can deal with. Administrative confrontations, I don't like. Doctors say they don't like politics, but they're willing to meet behind the scenes with the administrators of hospitals and concoct little schemes that way, okay? But they don't consider that politics.
And, I mean, in the transformation of healthcare in the United States, more and more doctors now are not able to have private practices. They're working for HMOs, they're working for insurance companies. How has that affected medicine?
Well, pretty badly. One of the things that they do at administrative levels to get people out of private practices to make billing complicated. And that has just been done with the passage of the RVS codes, which are now used to starting January 1st of 2014 to pay doctors. You don't just send in a bill that says $15 or $150 and get paid. The bill now goes through all kinds of arithmetical adjustments. And if you've made some kind of mistake because you didn't consider this and take off 3% here or add 4% for that, the bill gets stopped. Okay? And the insurance company benefits because while it is stopped, somebody is picking up a small fee each and every time the bill stops at the administrative level. And that gets charged onto the administration of healthcare. And a lot of time the administrators of healthcare like to make it seem as though that's the cost of medical care. It isn't. It's the untoward cost of administration.
So they're padding the administrative costs of getting health care?
Yes, that's how it's done. Okay? Now, people have caught on to that, and they try to say, well, we only want to deal with a company that such and such percentage goes to administration. And some companies can show you that they have much lower administrative costs than others. But the mere necessity to do even that costs the company something, and they have to make up for it some way. And what I'm saying is that in the small office, the 1 or 2 doctor office, or the small group practice office, where they have to have people in charge of billing to know which code to use and which modifier to stick on it, for example. For example, in our office, we might do a consult. If that consult has been requested by a qualified medical evaluator, then we are supposed to add a -30 modifier to the bill. And that's one of the simple changes. What I'm getting at is that these changes are so gross that most offices can't do them. So you drop out, do something else.